Hello everyone. Next 20 to 25 minutes I am going to talk about rickettsial diseases which are important to intensivist. Basically the first case of rickettsial disease was reported in India during Second World War during 1920s time in few countries or few states of our country like Assam, Madhya Pradesh and Kashmir. Then the mortality and morbidity were very high because of lack of specific management and supportive measures, and at the same time lack of accurate techniques to diagnose the disease. And it was well controlled after that. The mortality was has decreased to very much less. But again, in last 6 to 7 years, due to various environmental factors or urbanization, the disease has become re-emerging disease because of too much travel and because of environmental issues. These are few facts about the bacteria. It's obligate intracellular gram-negative bacteria, and the disease has been caused by the few genera like Rickettsia, Aurantia, Ehrlichia, Neo-Rickettsia, Neo-Ehrlichia, Anaplasma. All these genera belongs to your family Alpha Proteobacteria. And as per ICM 2015 classification, this group of rickettsial diseases have been classified as per clinical features into three groups. One is typhus group, second one is spotted fever group, the third one is others. Under typhus group, epidemic typhus, murine typhus and scrub typhus. In our Indian scenario, scrub typhus is the common. For all these diseases, the vectors can be mites, fleas or louse, and reservoirs, most of these diseases are zoonotic diseases, and the reservoirs will be some animals. Humans, for all these diseases or for most of the diseases, humans will be an accidental reservoir. Murine typhus is caused by Rickettsia prowazaki and typhi. Scrub typhus caused by Aurantia susugumshi. And all these three diseases shares common clinical features. Coming to spotted fever group, Indian tick typhus, Rocky Mountain spotted fever and rickettsial pox. And even this spotted fever group of diseases have similar, more or less similar clinical features like typhus group with fever, rash, multi-organ involvement. Only a few differences are there. In the typhus group, we can see S chart as a pathognomonic sign, but in spotted fevers, skin rash is the predominant feature. Others, Q fever and trench fever. Q fever has been removed from the classification of rickettsial diseases recently because of few distinct or few specific features of the bacteria. Coming to trench fever caused by Rockabillia quintana, Q fever caused by Coxiella burnetii, and the reservoirs for Q fever, cattle, sheep, goats. For trench fever, humans are the natural reservoirs. Scrub typhus, as I told you, all the typhus group of diseases shares common clinical features and common pathophysiology. Scrub typhus, rodents are the reservoirs, mite is the vector, and when human comes in contact with the mites accidentally, the mite can bite a human and can transmit the disease. Among mites, larval mites will transmit the disease called chiggers. Pathophysiology, the main target of bacteria is endothelium and immune system. Once the bacteria sits on the endothelium, it induces vasculitis, increase the permeability and starts perivascular inflammation, and all these will lead to end organ damage and multi-organ dysfunction. Immune system, both cellular and humoral immune system will participate in the pathophysiology. Once it activates the cellular immunity, it will release the cytokines like interferon gamma, GM-CSF, TNF-alpha and IL-6. IL-6 is pro-inflammatory cytokine and others are anti-inflammatory cytokines. The main mechanism behind the pathophysiology is this bacteria will down-regulate GP96 on the macrophages. This GP96 receptor plays a vital role in different functions of immune system like endothelial antigen presentation, dendritic cell function, antibody production, cross priming of immune system. So once it deactivates GP96, all these defense mechanisms will get impaired. Coming to clinical features, the incubation period is 10 to 12 days, and general features like fever, myalgia, arthralgia, GI symptoms. There can be maculopapular rash and in the trunk and extremities, lymphadenopathy and organomegaly will be there. SCHAR is one of the pathognomonic sign of scrub typhus. It starts as vesicle and progresses to central necrotic ulcer with erythematous border. And the common sites: groin, axilla, genitalia, nape of the neck, and anal areas. So once you suspect the scrub typhus, you have to examine all these areas for to not to miss to examine all these hidden areas. The incidence of SCHAR 7% to 80%. And coming to the timeline of clinical features, first week like fever, myalgia and rash. Second week there will be organ involvement. By the end of first week and during second week, there will be cytokine storm and vasculitis will settle down, and that causes multi-organ involvement. That can be cardiovascular involvement like myocarditis, CNS like meningoencephalitis, and pneumonia ARDS, AKI, hepatitis, and GI involvement will be there. Diagnosis: most of the diagnostic techniques are based upon the antibody detection. Will-Felix is one of the age-old technique having high specificity and low sensitivity. The principle behind Will-Felix test is detection of antibodies to various proteus species. So there is a cross reactivity between antibodies of the rickettsia and antigen of the proteus. So we take proteus antigens and mix these proteus species with patient serum. If there is antigen antibody cross reactivity, we can consider it as a rickettsial infection. It detects all the species except Rickettsia acri. Titers of more than 1 in 320 is a diagnostic of disease, or fourfold rise in the titers starting from 1 in 50 over 48 hours is also diagnostic feature. Other techniques for antibody detection: immunofluorescent antibody detection. It's a gold standard, but it requires immunofluorescent electron microscopy, bit expensive. All the hospitals may not have this provision. It differentiates all the species, and other main drawback is prozone phenomenon. This technique is based upon formation of antigen antibody lattice. So in case of antibody excess or in case of antigen excess, this lattice will not form. So this is called prozone phenomenon, and we may miss the diagnosis. Another technique is immunoperoxidase assay. The principle is similar to immunofluorescent assay, but it's a bit cheaper. It doesn't require immunofluorescent electron microscopy. ELISA, this is the most standard and widely available test, and it detects all the species. It's widely available and cheaper, and this is the most common technique that we use in our in our daily practice. Western blot test is for antigen detection. This is useful for large scale screening, especially for epidemiological purpose. PCR in case of complicated cases where patient immunity is less and may not mount the antibody response, or if there is prosthetic joint infections or vascular infections or infective endocarditis. To further confirm the diagnosis, you can do PCR. Cultures, the results will take 4 to 6 weeks, not advisable for routine clinical practice. Rocky Mountain spotted fever, the clinical features and pathophysiology more or less similar to typhus group. The predominant sign is rash. The incubation period is around 2 weeks. There it is 10 to 12 days. Treatment for both typhus group and Rocky Mountain spotted fever or spotted fever group is the same. Doxycycline 100 mg PD or 2.2 mg per kg per dose PD for 7 to 15 days as per the disease severity. For prophylaxis, 200 mg stat dose, and alternative chloramphenicol 50 to 100 mg per kg per day, divided every 6 hourly IV, and maximum 3 grams in 24 hours. And azithromycin 500 mg OD for 3 days, roxithromycin 150 mg PD, rifampicin 600 to 900 mg per day, and other alternative is ciprofloxacin. Trench fever is caused by Bartonella quintana. Louse is the vector. Incubation period 3 to 48 days. And the fever in this disease is having three distinct patterns. One is high grade fever with chills and diaphoresis. Second pattern is abortive, relapsing or intermittent form of the fever. Third pattern is continuous fever. The common features: fever with severe headache, retroorbital pain, neck stiffness, neuropsychiatric symptoms such as weakness, depression, restlessness, and insomnia, conjunctivitis, dyspnea, diffuse abdominal pain, weight loss, diarrhea, constipation, and all other organ involvement and organomegaly, especially severe myalgia will be there, neuronal involvement will be there. And this the main or distinct feature of this disease is the patients can present with following three syndromes. One is chronic lymphadenopathy. Patient is having only lymphadenopathy without any antecedent features like fever, myalgia, or any prodromal symptoms. The second syndrome, bacillary angiomatosis, with the distinct skin lesions without any without any regional lymphadenopathy. The third syndrome is endocarditis. Management: doxycycline is the drug of choice, but with extended duration of therapy around 4 weeks. And the first 2 weeks you have to add gentamicin 3 mg per kg per day. Macrolides and ceftriaxone are alternatives. In case of chronic lymphadenopathy, erythromycin is the drug of choice. 500 mg 4 times daily, around 2 grams in a day for 3 months. In case of angiomatosis, erythromycin, of course, like lymphadenopathy, erythromycin is the drug of choice for 3 months. Alternative is doxycycline. In case of refractory cases, you can add gentamicin to erythromycin. Endocarditis, here doxycycline is the drug of choice for 6 weeks, and you have to add gentamicin for first 2 weeks. Q fever, as I told you, it's not part of typhus diseases because of these three distinct features of the bacteria. It's highly filterable bacteria, resistant to all physical and chemical insults, and it will transmit the disease without the help of the vector. Because of all these three features, we can use this bacteria for bioterrorism. And during its life cycle, it passes through three morphological variants like large cell variant, small cell variant, and small dense cell variant. Once this small cell variant enters into the cell with the help of endocytosis, that's called phagosome, and this phagosome binds with the lysosome, will form a phagolysosome. It undergoes a series of replications and it forms a large cell variant from small cell variant, and after a certain period of time from this large cell variant, there will be production of small dense spore. This is the spore which will be resistant to all physical and chemical insults, so we can use this spore for bioterrorism. The main distinct feature in the pathophysiology is antigenic phase variation. This bacteria has two phases during its life cycle, phase 1 and phase 2. In the phase 1, the external lipopolysaccharide layer is very much complex and it will act as an antigen. During phase 2, this lipopolysaccharide will undergo subtle modifications and become less complex. It exposes the underlying protein. So here, during phase 2, protein is the antigen. During phase 1, lipopolysaccharide is the antigen. Phase 1 will be more virulent and can cause chronic infections. Phase 2 is simple and non-virulent infection, lasts only for a brief period of time. The pathophysiology is same like typhus group of diseases. IL-10 is the pro-inflammatory cytokine. The risk factors: the persons who work in the farm animals, who handles the flesh of the infected animals like slaughterhouse workers. Here, patient can have multi-organ involvement along with the general symptoms like fever, myalgia, severe headache, retroorbital pain, pneumonia, ARDS, hepatitis, AKI, myocarditis, lymphadenopathy will be there, CNS involvement will be there. Here, in case of hepatitis, if we can do a post-mortem biopsy, we can see a donut granuloma with the presence of lipid vacuole surrounded by the fibrinoid ring. High risk for chronic infections: valvular heart diseases, vascular grafts, joint prosthesis, and immunocompromised patients and pregnant group of population. During diagnosis, you have to check antibodies both for phase 1 antigen and phase 2 antigen. In primary infection, a phase 2 IgG titers of more than 200 or IgM of more than 50 will be significant. Persistent high IgG titers associated with chronic infections. In case of immunofluorescent assay, there can be cross reaction between Coxiella, Legionella and Bartonella species. And PET-CT in case of complicated infections like vascular graft and joint prosthesis or endocarditis. In such scenario, you can consider PET-CT. PCR in all these chronic or complicated infections to confirm the diagnosis. Cultures not routinely indicated, but if there is endocarditis, patient who you think requires more than prolonged therapy, more than a month of therapy, you can do get cultures done. These are the diagnostic criteria for endocarditis, vascular infections, prosthetic joint infections, osteoarticular infections. Definitive criteria: positive culture or PCR for all these infections. Major criteria: present positive microbiology and high titers more than 6,400, and along with a positive radiological finding, either echo or PET-CT or normal CT. Minor criteria: less titers more than 800 but less than 6,400, with other supportive features like fever, thrombocytopenia or fever arthralgia. So fever, presence of prosthesis, so other supportive features. So to diagnose, for definitive diagnosis of chronic infection or persistent focal infection, one definitive or two major or one major and three minor. For possible, there not be any definitive criteria, only one major and two minor or three minor. This is a case scenario that we have seen around 3 years back. She is a young female, 30 years old, presented to us with history of fever and severe myalgia since 4 to 5 days. Fever was high grade, 101 and 102. All the initial labs suggestive of leukocytosis, thrombocytopenia and AKI hepatitis. CU was showing 6 to 8 pustules, proteins 2 plus cast present. So we sent both blood and urine cultures, and we thought in lines of either UTI, complicated UTI and sepsis, or tropical disease. Because in our scenario, whenever there is thrombocytopenia, multi-organ involvement with leukocytosis, we have to rule out all the, we have to do all the tropical disease workup. And we started her on beta-lactam antibiotics along with doxycycline to cover tropical diseases. But fever-wise, there was no much improvement. Counts were also, it's almost like static, 15,000, 16,000. Platelets were slightly on decreasing trend, 1,90,000. But on day 4, she complained of severe headache and had GTCS. We thought it is meningitis, and CT brain was done and done CSF analysis. But the CSF analysis showing a low normal sugar, proteins are around 60, counts 20 with 80% lymphocytic predominance. We did not act on this because it is a spectrum of tropical disease or any rickettsial disease. Meningoencephalitis is one of the presenting feature of any rickettsial disease, or even leptospira also can present like this. So we did not add any further antibiotic because on the same day we got scrub positive. So it's basically a complicated rickettsial disease. We continued with the doxycycline for about 2 weeks, and after 2 weeks we switched over to rifampicin because she was having severe gastritis. So to summarize, any in our scenario, Indian scenario, where the tropical disease for the tropical disease we are endemic zone. So whenever patient presented to us with fever, thrombocytopenia and multi-organ involvement, along with other regular septic workup, we have to do parallel tropical disease workup also. In the history, we have to be very much stringent regarding history of occupation, history of travel, and history of any visit to forest area, and if he is a slaughterhouse worker or if he is handling the cattle Then we have to, if he works in the mines, actually the woman that I presented, that I have shown in that scenario, she's a coal. She was working in Singareni mines, so that is also one of the risk factor. And for all tropical diseases, especially leptospira and rickettsial diseases, ELISA is a diagnostic of choice when patient presented to you by the end of first week or during second week, and most of them present so because initial 4 to 5 days they'll be having a fever, myalgia. Mostly they will neglect and they will try to take the local doctor or RMP's consultation. In case of complicated cases, immunocompromised, where patient may not mount the antibody response, you can consider doing PCR. In all suspected cases, add doxycycline on the first day itself to decrease the morbidity. Thank you.